So, as I said, ambulance director. So happy to be here to talk to you about our annual review. Really, the first thing on the list is our staffing, because that is really the most important thing for us, because our primary focus is to provide care and transportation of people in need in Johnson County. So that is the biggest thing, and honestly, most expensive thing that we ask for every year. And so as of July 1, we became a county that has 5 24/7 ambulances, which is an amazing progression from where I was when I started in 1999. So very excited to be able to get to that point of coverage. In addition to that, we have 6 ambulances staffed from 07 in the morning until 23 or 11 p.m. at night. So good coverage here. And this is not asked for without data to back it up. We have an analytics committee that every year will pull the data from the Joint Emergency Communication Center, analyze that data, looking at the time of day, the day of the week, how many ambulances we have staffed, how many calls are coming in, to then determine where we might have some shortfalls, and so how we could then best proceed to ensure our coverage. So very happy that we had that increase in staffing. The next thing that we have incorporated in this last year is our mobile integrated health program. And later on in the presentation, I'll show you some success stories. But really, I just wanted to highlight that this is a new addition and something that we're very excited about. This is an opportunity to fill gaps in our healthcare by creating connectivity between our healthcare partners, our community partners. So it's really connecting the fire department to the ambulance service, to the ERs, to the shelter house, to population health, and really creating an opportunity for all these agencies to be able to communicate together. And anybody that remembers the data-driven justice, this is really in that realm. And so it's exciting to be able to kind of return to that possibility. In addition to that, the 4 remaining things on this slide are things that maybe the members of the public wouldn't see. These are the things that are occurring behind the scenes, that are often occurring on my desk or on our assistant director, Ben Simon's desk. So the first one is the Medicare ground ambulance data collection system. And this was a mandate. This was a Medicare mandate for every ambulance service across the nation, split up over 3 years, a little bit of a delay with COVID in there, but really it was, if you were in year 1 or year 2 or year 3, that was your reporting year, and ours was just in this last year. It, as I said, was a mandate, and it was really an attempt to analyze cost, revenue, utilization of ambulances across the nation. So then this Medicare advisory group can then report to Congress on what they believe the cost to deliver ambulance care should be. So it was really important to make sure that our numbers were accurate and represent our true need. So that took a lot of time. In addition to that, we had the Medicare PCOS revalidation. This is a process that usually occurs for people that bill with Medicare, or agencies that bill with Medicare, every 5 years. But again, with the pandemic, this was my first opportunity to be a part of the revalidation process, and here I am 8 years in. So I got to get my feet wet in the provider enrollment. I'm gonna baffle it. The provider enrollment chain ownership system, also known as PCOS. So again, that was time consuming, but is complete, and I was happy to have that done. In addition to that, since 2011, the ambulance department has been part of the state program Offset. That Offset program allows state agencies to collect debt that has been unpaid. This is, again, something that we've been a part of since 2011, but in this last year, the Department of Revenue took over that program, renamed it the Set-Off Program, and then required a new MOU and then an ordinance. So in this last year, we worked with the county attorney's office, got an ordinance, and have reapplied successfully to the Set-Off Program. So again, just time-consuming paperwork, but necessary for the service for income and revenue.
Which seems like a really weird and terrible name.
They had an opportunity to come up with something fun, but.
Well, and this one makes it sound like people are mad, set off,
Yeah.
but offset.
Yeah.
So that's
Here we
crazy.
I digress.
Yeah, and then the last thing on the list is really all credit to Ben Simons, the assistant director. He reapplied and submitted our application for recertification for our accreditation. So happy to be in cycle 2 of that accreditation, and very appreciative of Ben Simons.
I was just going to ask Fiona, this is how many years then?
This is our, it is I think a 3-year time span that you are in, but the very first one is condensed. I think it's only 2 years because
Okay.
you're new.
Okay,
And after you're new, then you can graduate into the slightly
Okay.
extended, so,
okay,
yes. Additional operational updates, trying to be more welcoming and accommodating for people in our community where English isn't their first language. We have had every form that the ambulance department uses in patient care translated into English and Spanish, English, French and Spanish. So have those accessible and available to our patients. So we're very happy that we finally got that launched. Also, we have launched our second EMT apprentice, and so thank you to the Board of Supervisors for continuing the ARPA-funded apprentice program. Our first candidate, Amani Iker, graduated and very successful and is a full-time member of our team. And now we have Katie Smith as our second EMT apprentice, and she is fitting in perfectly. So very excited to have that. The third item on the list is an Aegis wrap, and that is the center picture there. So in the decades I've been in EMS, there has never been a safe way to transport a newborn. And so either you're holding the newborn in your arms, which is not safe, or separating mother and child, and securing the child safely, but it's not great for that skin to skin bonding just post-delivery moment. And so we've always been looking for another alternative. And this Aegis wrap, it launched a couple years ago, and we did not incorporate it then because they hadn't done all the safety testing that we felt comfortable with. And so finally, they've done all the safety testing, rollovers, you name it. And this is a very safe device to be able to transport a healthy newborn in skin-to-skin contact with the mother. So happy to be able to launch this and to be able to keep that connection in place. So in addition to that, we have a pelvis sling on the ambulance. This is just a new, it's a not expensive, but a tool that we can use to help with hemorrhage control. So if somebody has a pelvis fracture, this pelvis sling will help stabilize the injury, which it helps with pain control, and then also can help with that hemorrhage control. So very happy to have that as one of our new tools. And then lastly, the lactation room. So we moved into our beautiful building, which we love. Thank you very much, in 2017. But as you grow with a building, you see where there are maybe some things that could be changed or improved upon. And we realized that we needed a lactation room. And so we've got one created. It's not the end product for all times, but it is definitely something that we can utilize for our staff and other staff in the building. So that's been a good change. And we worked with a physical plant for that as well. So good collaboration.
Does it have a refrigerator then?
Yes.
Good. Okay.
All right, so while we achieved heart safe community status the year prior, in this last year, we all gathered with our local community government to disperse our heart safe signs. So really appreciate the opportunity to be able to bring everybody together with all of you and the Rotary Kerber, and to be able to get these signs out into the community, which are celebrating the fact that we have met the 13 critical criteria to be designated a heart safe community. So very happy about that. Our AED program and partnership with the Rotary Kerber is continuing. Our ongoing public CPR education is thriving. I'll touch further on in the presentation about our PR and educational events that we've accomplished. But then lastly, we've got an ECPR program. And so that is an additional layer in partnership with the University of Iowa Emergency Department to enhance survival from sudden cardiac arrest. What it means is basically we've got a patient in the field that is suffering from cardiac arrest. If they meet certain criteria, meaning they are in a shockable rhythm, a recurrent shockable rhythm, then and a couple other like factors, if they meet those, then they will qualify to be part of the ECPR program. Our crews call into the ER and say, we've got this candidate. They then page their team. And it means that this person will be, expedited to the hospital and hopefully connected to ECMO, which is an extracorporeal, I tried to memorize it, extracorporeal membrane oxygenation machine. And so basically it means that it's a machine that is going to oxygenate the blood for the person to help them survive from that cardiac arrest event. So it's like what you see on Grey's Anatomy. It's very cool.
You
So
know,
very happy. We had 8 individuals that qualified, 5 that were accepted into the ECPR protocol, and 1 that actually made it to ECMO. So it is new and fandangled. We're very excited. Anything that we can do to improve survival statistics. And Dr. Pete Georgakakis, our medical director, wrote an article, and it is in the AMA Journal of Ethics. So feel free to check that out. Welcomed another medical director, Dr. Tom Striegel. He is overseeing the Mobile Integrated Health Program, that community paramedic. It is a different scope. It is the same scope as paramedic, but they have so much more training that they need to do just in regards to like community outreach, learning what community resources available, medication management, lab values. So we needed a medical director to oversee that program to make sure that we are safe and compliant. Also welcome our new EMS fellow, Dr. Ben Wilkinson. We have a great relationship with the University of Iowa in regards to partnering with them with paramedic students, EMT students, ER residents, you name it. But this EMS fellow program is fabulous because we have an EMS fellow that comes and rides with our crews, provides feedback, is part of our chart audits, is part of our education, is basically we have an in-house doctor for a year, and it's really a wonderful opportunity. And it's great for the university as well because they get to have this fellow experience our service. They also work with area ambulance, Cedar Rapids Fire, Iowa City Fire, the bomb team, Jack, you name it. This is just a wonderful two-way street for both entities. So happy to be a part of that. We launched Kudos update monthly. And so this has been really nice for kind of staff morale. It's a QR code that empowers staff to recognize coworkers that go above and beyond. And what's nice is that Haley Wilson from Public Health compiles the data for us. And so then she'll get to see it first. She's like, oh, she's like, I recognize these faces from the DISC training. So thank you, HR, for putting on great training where we all get together. But ultimately, it's not just our people recognizing ourselves. It's our people recognizing IT, our people recognizing somebody from the sheriff's department. And so it's evolving, and I love that. That was natural. It didn't have anything to do with me. And so I love the people at the ambulance department. I love the county, but I'm just really proud of the ambulance department. So in addition to that, we have a QR code for compliance. We've got a compliance program. And so this is just another opportunity for somebody, if they see something and want to say something, it's just an easy opportunity for them to help keep us safe.
So is that like reporting something that might be a safety hazard or what is it?
It could be, I'm confused about the way a chart was written and I feel like I did it wrong, or somebody is doing this, or there's a safety risk, or I don't feel comfortable. Maybe it's somebody doesn't feel comfortable just bringing that information to my door. I mean, so much of what I do is creating opportunities for people to give me the information that they need, because not everybody wants to come to my door, which I always welcome. But we create QR codes and email links and you name it. So it's just to make sure that people are willing to share the things that we need to.
Well, and you're 24/7, so you're not always
Exactly.
in when they're in too,
Exactly.
so,
Good
yeah.
point. So this next slide, this has been something that has been in the works for many years. When we would put out a SWOT analysis, we would get the feedback of there is no growth opportunity in this department. And I said, you're right. How do we fix it? And so ultimately, this last year, we launched a union-based leadership position. And it's literally launching right now as we speak. We have interviewed and selected, and they start orientation next week. So really happy. We've got 2 day shift, 2 night shift, 2 education focused, and then 2 for GuideLink. So we're super excited. It's just really going to give an opportunity of growth and leadership opportunities for staff. So when we have an opening in management, or there's an opening for, whatever it else the person wants to explore in their life, they will have gotten that training in-house. So we're growing our own, which is really nice. I'm very happy.
Now, if they ever redo like Adam 12 or something like it, street has the looks and the name
I know.
to definitely star in that episode.
Yep, we gotta come up with here. All right, so this slide is just really highlighting our call volume and our staffing levels. So interesting, just general information to see that our call volume increased 6% over last year. Okay, that's great. But then you look at how much it's increased over the last 4 years, and now we're at 25% over the last 10 years, almost 70% increase in our call volume. So when we get to the slide about our expenses and revenues, just remember how much growth we've got here. It's also important to note our staffing, because we want to see how we're doing. Are we keeping up? And you can see that really in the time of the pandemic, we were at a deficit. We were sitting short with unable to fill 4 full-time positions. And I presented to you all, you understand part of how we got to that shortage, and the pandemic certainly didn't help. And so it's really, this slide is to help you see that we are finally fully staffed and at a good marker in regards to our call volume. And this makes me be able to sleep at night, because I know that we have the right amount of staff to respond to the call volume of our community. Fund data, 15,539 calls last year, again, 6% over the previous year. Busiest day was Saturday, with Sunday being a close second. Busiest month was October. Now, take note that I will bet when I'm talking to you in a year's time that I will tell you that September is the busiest month, because this year we have 3 home football games in September. So take note. Busiest time of day, 4 p.m. Urban response time, 7.5 minutes. Rural response time, 16.5. These are all well below our required markers. And we had 110 cardiac arrests last year. These are the services that we offer at Johnson County Ambulance Service. Obviously, first and foremost, 911 care and transportation. Sobering services at the Guideline Center. Mobile integrated healthcare with our community paramedic. Ongoing community partnerships and community education. Pulse Point, Heart Safe Community status. Accredited and compliance programs. Lastly, our EMT apprentice. With all of these lovely things come cost. So, breathe. This slide fluctuates. These numbers fluctuate. And when you look at 2022, I love looking at that slide, that one line. If I could just look at that line always, that would make me very happy. However, it's not an accurate representation of running the ambulance department. That is the year that we couldn't fill 4 full-time positions. That is the year that we were not meeting the needs of our community, because we couldn't fill the positions. So that is, as lovely as those numbers look, it's just not accurate. So with fiscal year 23, we had to get those 4 positions filled. We had to increase wages to be able to be competitive with our, our market. And so really, with the majority of my budget being staffing, that is not surprising. And then we go into fiscal year 24, and we're still seeing a large increase. And that's when you also have to take into consideration that it wasn't just staffing that we had to increase. We're coming out of the pandemic and the supply chain shortages, the increase in cost for our medical supplies. Our ambulances increased like $500,000 to $600,000. So it's really not as simple as just saying, gosh, that ambulance director, she's just spending money. We're really, we're spending the money that we need to be able to provide the services that our county, is asking for and needs. And we're also actively looking for ways to increase the revenue and to decrease those costs, whether it's looking for the opportunity to be able to bill for transporting patients to the Guideline Center, whether it is looking for alternative payment methods for mobile integrated health, whether it is working with our insurance companies to actually make sure that we're getting compensated for the appropriate amount. So often our billing coders have to continually go back and forth because we're getting a rate that is in network and we're not in network. So there's a lot of work that goes behind the scenes. And I just want you all to know that these are taken serious, these numbers, and we're always actively looking to make the reductions where possible without compromising the quality of care that we're delivering, and also looking for ways to increase the revenue. So,
I'd like to just talk a little more about this. So, I remember pretty well, before you were the director, having some really the director at that time having some real heartburn, some conversations with us about numbers. And when you say county support, that's basically our local property taxes. And when that number had reached 800, 900,000, and he was pretty stressed, and we had conversations about what that means. And then, of course, we had a lot of real positive things happen with the ground transportation, and I mean, we've had a lot of really good changes with the set off and the
Yeah.
ground transportation, things like that. We have a lot more revenue for ambulance than we used to. But that's not even close to that increase in that growth that you talked about, 70%.
Mhm.
I mean, people have to think about that. That's remarkable. And so I think actually the fact that we're only this much above where we were for a long time, that 900,000 number, is really pretty remarkable that it's only gone up, it's only doubled, but our calls 70% higher, so it's actually, I think, a really good sign.
Well, and also we had where you had the time, you charted for us, the number of times that there were 0 ambulances available, and that was daunting to think that there were those moments, even, I mean, it's chunks of moments, but we couldn't provide. And, you also had a kind of a replacement schedule for the ambulances. And that was when, they were at this price, and then after that, supply chain and everything, they were way beyond that. You actually actively found a way to where we were able to get one now and do, and it was just sort of like this.
Got a twofer.
It was like it was like this great hat trick, but it really saved a great deal of money in that context. I mean, compared to the years before, it was outrageously expensive, but in that context, we were able to get 2 for 1. So that was, really appreciated.
I don't know if I would imagine this is the same for all my colleagues too, but when I'm out in the community talking to people and they have concerns about county budget, this is not something that typically comes up. There's that 1 out of every 100 people that any county expenditure is bad, including ambulance. But for the most part, people, when they know that money's going into ambulance, they see the results of what you folks do. You're pretty visible in this community, and they have a great deal of appreciation for it.
Thank you. I appreciate that. That really is one of my goals, is just to be present in times that aren't just an emergency. We want to be there for the good times in addition to the stressful times. So I'm happy to hear that. This is our payer mix. This slide doesn't really change too much. Our Medicare reimbursement usually sits in the 40 to 45%, and our Medicaid sits in the 20 to 25%, and then the rest just kind of follows suit. So no big changes here. Our guideline center had the busiest month since they opened last month. They had 70 people in the sobering unit. So while that is a challenge for those people, it is wonderful that we are available to provide that resource to the people in our community that need it. So I was very happy to see that. Ongoing education and growth. So we are just launching into a trial with the University of Iowa. Our crews love that. I mean, it is an opportunity for them to learn and be cutting edge, and that's one of the perks of being in the teaching community. And so this is the impact on pre-hospital sepsis protocol. And so really it is our crews recognizing sepsis sooner and then getting our patients to the ER sooner so that they can actually get the antibiotics that they need. So very excited to be able to work with the University of Iowa and also Emory on this project. So very exciting. We're an NAEMT training center, as you all know. Then this last year we had hosted a pre-hospital trauma life support class, advanced medical life support class, tactical emergency casualty care class. We have launched a RAS score, which is the Richmond agitation sedation scale. And so ultimately just kind of a tool to help measure level of consciousness and level of agitation to be able to provide the best care. We hosted and participated in specialized transport training. So it's really training on those highly pathogenic patients. We've got a good partnership with the University of Iowa's highly pathogenic team, and then also with the Nebraska team, medic out of Quad Cities and West Des Moines EMS as well. We participated in the active threat drill at Clear Creek and Manna, and we'll be continuing with ongoing training for our staff in regards to that. And then lastly, our staff has completed unconscious bias and respectful workplace training. This slide is something that we're pretty proud of. So we achieved the Mission Lifeline Silver Achievement Award. And this is something that we started working towards 3 years ago. Jared Camp, our field supervisors, is really instrumental in applying for this and gathering the data. And when we saw deficits where we saw room for improvement, Jared then worked with Alicia Meter, our education supervisor, to make those changes to be able to get us to the point that we would achieve this status. So what does it mean? It means that we're dedicated to the wellness of our community. It means that we saw room for improvement in ensuring that we were checking blood sugars on all of our stroke patients, that we were getting aspirin in for all of our patients suffering from a myocardial infarction, that we were making sure that we were getting a 12 lead done within 10 minutes of arriving on scene of somebody having chest pain. So making these changes, making sure that these changes are then documented, then we were able to achieve this goal. And so this is just truly indicative of the fact that our department is living up to our mission, which states that we're continually striving to learn, improve, and grow, enhancing the quality of care we deliver. So boom, we did it, and we're going to keep doing it. And so this is something I'm very proud of and happy that we were able to achieve. This next slide just really further brings home that, you know, our level of care is exemplary, always wanting to increase our survival statistics. And so I want to be more than 5% above the national average, and we will get there. But currently this is the readout from our CARES report, which is our cardiac arrest data to enhance survival. And ultimately it says that we've had 110 cardiac arrests. 25% of those had ROSC, which is the return of spontaneous circulation, which is great. And 14.3% of those were able to be discharged from the hospital neurologically intact. So these are great strides. It means that the things that we have in place in a heart safe community are doing what they need to be doing. Our aggressive protocols, our citizens participating in CPR, and wait till you see the next slide. It just shows that the things that we're doing are actually making a difference. This slide is just, again, more data from the CARES registry. It shows we're in orange, red is the national. So it shows that we see more of the cardiac arrests occur, which, while that is traumatic for the person witnessing the event, it is beneficial for the person experiencing the cardiac arrest. So that is best case in regards to being able to start CPR sooner and get an AD in place. Look at that second column. Holy cow, that shows that almost 70% of the cardiac arrest calls, a bystander started CPR. That is massive. Look at where the nation is. That is impressive. So this is showing that our community is willing to step up. And so this is exciting. Third column, we're about national average. It just means that, you know, the person was in a shockable rhythm when we arrived. And the fourth column is something that was a little surprising to me. It shows that we're below the national average on our AED use, which is surprising since we have such a rigorous public AED program. And the Rotary Kerber, I'm sure, will be very interested to see this number along with me. And so we've got more work to do because we have a very, you know, present AED community. We've got so many available, and now we just need to make sure that people are actually accessing them.
And this is just for last year.
Yes, this is just last year.
So, yeah.
Well, a question about that. So given that the CPR, bystander CPR is so high, is it possible that that is getting to the response, or, you know, the patient needs to be without get into the AED? And is that why that might just be kind of
Instead of a
low, or do you think it's more of a
They
not comfortable
usually go hand in hand, because even if they don't need the shock, even just applying it, we want. So
Okay.
I mean, it could just be that, you know. It
Well,
could-
like V said, it's 1 year.
Yeah.
Data can do a lot of weird
Yeah.
things over 1 year,
Yeah.
so.
But yeah, we want people to use the AEDs even if they don't deliver the shock, because the machine will do all the work, and so just put it on, and then you've got the metronome. It's
Mhm.
just, so it could just be any number of things, but hopefully it's not because people were unwilling to access it. So maybe they were just all completely removed from the AEDs that we have in place, so we'll see, but we'll investigate that, so.
Good.
Next slide, this is just the community partnership and education. We provided CPR at Jazz Fest, at Arts Fest, we're at job fairs. You know, the On Iowa orientation event for the University of Iowa, you name it, we're out there. In these pictures, the CPR events I just mentioned, but then that bottom one is Amanda Bosker, my Sharpfield supervisor. She's part of the planning committee for Safety Village. So that is just an annual, week-long participation that we are part of, and just love to do that. The picture on the right is our collaboration with, Iowa City Fire Department, providing, training on how to best care for a firefighter down. They've got, you know, all that equipment, so how can we care for them in those situations? We had 55 PR events, and we had over 7,750 community interactions. And that is not our call for service. That is on top of our 15,536 calls. We had all those public interactions. So very, very much out there in the community. Pulse Point Respond update, we actually have 4,600 downloads now, so I'll make sure to upload that or update that before we put this on the website. But we have 466 AEDs in the community, 40 of those are available 24/7. And this picture on the right is the most recent AED 24/7, and that is in Tiffin, and that is located at Roberts Ferry Road and Marengo Road. Mobile integrated health. So this is the program that we touched on earlier. Again, this is really the intent to close the healthcare gaps. It's creating that connectivity between us and other community partners. It's reducing the ER visits. It's reducing 911 activations. It's improving quality of life for the individuals. It's helping with medication management, fall risk, you name it. This community paramedic, it has seen many, many things in the few months since he has been launched in this full-time position. Couple of success stories. One is a recent 65-year-old patient that was referred to the MIH program, high utilizer for all services across the board, complex medical conditions. And when Mike got there, it was very clear to see unsuitable living conditions. So very, very difficult to manage, for her to manage her care in the living conditions that she was in. And so in this assessment with Mike and the connection with community resources that just hadn't previously been able to be made, this individual was transitioned into stable housing, is now able to manage her care better in a stable environment. And as a result, the reduction in ER and emergency services is significant. This story here is a middle-aged patient that was having struggles with their living environment. And as a result of the stressors that came with that living environment, it was manifesting themselves in regards to like medical signs and symptoms. And so ultimately very, very high utilizer of all the emergency services. And so initially had a great interaction, got this person connected with the Iowa Bike Library, who donated a bicycle, and one of our paramedics donated the trailer, and ultimately allowed this person to start their own lawn care business and start having income coming in. So that also the income, the healthy outlet for the stress reduction really helped and reduced the emergency use for this individual. Definitely still a part of the program, because there are still ongoing issues. It's not just a easy fix. Oh, we gave them a bike, end of the story. So definitely still part of the program, but very, very clear little victories along the way. Mike currently has seen 21 people since July 1 in the MIH program. Probably about 2/3 of them are still active in the program. And that could be anything from just, I'm gonna follow up in 1 month to, see how sobriety is going, making sure that your medications are still on point. Or it is a much more hands-on, interaction. And again, we're partnering with the VA, University, Population Health, Sheriff's Department, Shelter House, community, public health, you name it, social services. These are all different agencies that we have tapped in to, help make these connections.
Yeah.
Rod will remember this, but back in the planning times before we got to GuideLink. And Jessica Peckover created this thing she showed us about points of intercept. And like if we could only find for these frequent utilizers of the system, like if we could only find that place, that common place where we could have been proactive. And it was a 911, it was 911 calls that maybe didn't really rise to the level of 911
Yeah.
calls, but that was the common thing in each one of them. And this just, it's right to it.
This is it. And
It is.
so in the partnership with the, conversations with the sheriff's department, it's like, there are people that are getting released from jail and don't have the support when they get out. And immediately the same problems start occurring. It's like, so if we can have that warm handoff when somebody's getting released from jail, that individual that has had a fair amount of medication management, while they were in jail. Or let's say somebody, we're partnering with the VA to talk with Dr. Abrams about getting people their monthly injections for their psych meds before it gets to the point that the sheriff's department has to be activated for a committal. It's like, there are so many ways for us to utilize this program. And so I just stay tuned. I'm
Yeah.
excited. It's very,
This is an incredibly exciting program, and thank you so much for spearheading it, and thanks to Mike for all of the hands-on. I know that he also enjoys it, but we're so fortunate to have a community paramedic in our county, and I am just very excited that this is officially launching and where it's going to be headed. I'm sure it's just such a huge gap that it's filling. So thank you.
Thank you.
Well, and thanks to everybody really, because Mike doesn't go on all the
Right.
911 calls. It's the other folks who have to recognize
Yeah.
this is a place to refer
Yeah.
this person to Mike. And so your staff is obviously doing the work.
Yep, so they're doing the referrals and making those connections, and then it's also thanks to our community partners, because they are opening up to the idea of, oh, there's this one person, we're calling them a community paramedic, what is that? And am I really meant to share with them? And to then actually be able to see that, okay, yes, by breaking down these silos, we are actually able to see improvement in the patient care. So it's pretty exciting. It's very exciting. So in what's coming next, couple of, the first one's just silly, but it's, something that's been on the docket for ages. While I feel like our uniform is nice, but when you're going to a special event, whether it's an award ceremony or, God forbid, a funeral, this isn't appropriate. And so to be able to have something that we can put on to look more formal is important, and it's important to the staff and it's important to me. So working on that right now. The next one is we're in communication with somebody to offer a pre-crisis program. It's really a community building type mentality to really kind of help support and build up a staff pre-crisis. And this will be something that will enhance our current peer support program. Third one is something that I encountered in I was part of the Cardiac Arrest Survival Summit in San Diego last year. And this was a prominent topic of, you're pushing and promoting for people to be doing CPR in the community. And you get there and you take the person, you rush them off to the hospital, and then that person is left there with this traumatic event that they just experienced, providing this care, and there's nobody that follows up with them to say, you okay? You did a good job. You did what was right. And so to be able to gather that information in real time of who's there, who provided the care, and then to follow up with them. And that is sometimes a family member, sometimes it's a bystander. And so to be able to kind of initiate a survivorship program is really a direction I'd like to head. And then last,
for what it's worth, I know several years ago, one of the things that came up in the negotiations, interestingly, for the folks who are 911 dispatchers, was that they weren't getting the loop closed. You know, so
The
this
trauma for them.
yeah, so this person is in this terrible situation and I did what I had to do, and then I never knew what happened.
Yeah.
And so they started just simply closing that loop
Mhm.
for them, and it really had a big impact on employee morale and just job satisfaction, and they just wanted to know what had happened.
Yeah, that loop closure is important.
Yeah.
And really, we have incorporated dispatch in addition, the EMS fellow, the ER staff, anybody that we have that has come in contact with a particularly traumatic call, we are incorporating all those people into the debriefs. And so in the last few years, the debriefs have really evolved into a much more all-encompassing, entity, and it's mutually beneficial for all those agencies. It's unfortunate that we have to have them, but great that it's opened up to everybody, and it's really very helpful. So, and then the last thing is really in partnership with what we've been talking about with MIH and the data-driven justice. It's continuing that ongoing partnership, and it's looking into the option of something called health call. When Mike, Dr. Striegel, and I come to present about MIH and kind of our findings in October, we'll talk to you about health call. It's a program, it's software that creates all those connections that we wanted the data-driven justice to do. It makes it so we can safely share that data across the silos in a safe and protected manner and be able to make those connections in real time. Because right now it is still very clunky for Mike to be able to get the information that he needs and then share the information. And this health net is being used across the nation with other MIH programs, and it is looking pretty promising. So stay tuned for more information on that. Action items for the people that will be watching this presentation in the future: write to your congressman and support the Access to AED Act that is going to get AEDs into the schools. So please support that. Know the signs of cardiac arrest. Activate 911 early and often in those cardiac arrest settings. Learn CPR, be willing to use it, and download Pulse Point, because those are the ways that we're truly going to be able to increase those survival statistics. Lastly, this slide shows two fun events that just occurred in the last year. First on the left is we were training on new piece of equipment. I thought it would be funny to have them put me on a stair chair and bring me down the stairs, and thankfully they didn't launch me. And then on the right is just a group of us going out to see the eclipse. So my takeaways and leaving points for you all are just to have fun and be safe. And if you have any questions about the ambulance department, feel free to reach out. I'm happy to talk about it all the time.